first of all, welcome everyone. Tomorrow will be 5 months since Support at Home started. It feels, it's been an interesting 5 months to say the least. I will say the rollout implementation has been, a bit of a shambles to say the least. It's, at this stage, the reform, it sort of seems to be, it's been disappointing to say the least. It kind of seems like it's worse for providers and consumers. So I do think there will need to be changes made to the program to improve things for everyone. So again, that maybe presents opportunities because it's been a bit of a debacle for anyone who's been around or been involved in. It's getting a lot more mainstream media attention now with how much particularly for the consumers themselves, it's really affected a lot of people negatively. So hopefully, we're going to talk where things are at right now, but hopefully, there are some improvements and things made in the future. And in terms of this webinar, this is going to be framed from the perspective of an allied health NDIS provider who's thinking about aged care as a revenue stream. So if you don't know anything about Support at Home, this webinar will still be useful. And then even if you're already doing a bit of work in this space or a lot of work in this space, hopefully it'll still be useful as well. You'll still learn some new things. Again, I'll cover a few things like, pricing, compliance, what registered providers are looking for. So again, it'll still be useful no matter what, no matter the amount of involvement you have in Support at Home or not. So there is a lot of interest clearly, but I gave a week notice for this webinar. I just thought, why not? Good timing. And we had a lot of signups on LinkedIn into this webinar. So been a lot of interest. And again, not just from an allied health perspective, but I've noticed a lot of, NDIS, SIL, support worker providers are now adding aged care onto their, onto their service list or onto their website, wherever it may be. So there's a lot of interest. Again, there's obviously a lot of uncertainty around NDIS at the moment. So a lot of interest in Support at Home, clearly. And again, just simply adding aged care, and saying, hey, we're going to offer it. It's not that simple. I'm going to break down why it's hard to break into this sector. It's very, very different to NDIS, which we'll directly compare and we'll look at in a second. But a lot of interest, a lot of competitiveness in this market. So we'll break it all down as we go through. But without further ado, let's get started. Excuse the tech issues. All right. Residential aged care. So I started my career there. Started my career in residential aged care. Progressed quite quickly there. Whilst I was there, began studying a Master's of Gerontology, which I did 2 years of and graduated with a diploma of gerontology. Again, always been super passionate about aged care, both residential and community. After a few years there, had the opportunity to co-found and launch a national allied health company. So 2020 we went from startup to basically being a really large national company. So about 300 clinicians, about $15 million annual revenue or so. Our revenue split was probably about maybe 80%, 75% NDIS, about 15 to 20% community aged care, HCP, CHSP, STRC, that type of thing. And we offered about 10 different disciplines across Australia. So a really large, successful national, mobile allied health company. End of 2024, decided to exit and try something new. That's when I started this consulting company. So I was always a pretty average clinician as a physio, but I've always got a lot of non-clinical things that clinicians aren't good at. So, systems, operations, business, leadership, all that type of thing. And I've always loved helping people and loved solving problems. So consulting seemed like a bit of a natural fit. So been just over a year of consulting now, working with allied health providers of all sizes, sole traders, startups, large national providers, not-for-profits, PHNs, that type of thing. And again, I have that experience across sort of the NDIS sector, community aged care, residential aged care as well. So I sort of go across both, and it's one of my, niche areas. So I've worked with a lot of providers over the past year about, diversifying from NDIS into support at home, amongst a lot of other things as well. All right. So yeah, what changed? How did we get here? So basically, we had the Aged Care Royal Commission in 2021 that, drove this aged care reform as to where we are today. As a result of that, we had the new Aged Care Act 2024, which replaced the 1997 one that commenced the 1st of November last year, which was delayed from the original planned 1st of July date. So this support at home program replaced a couple of funded programs from the old scheme. So they were called home care packages, which I'm sure you guys have heard about before. And then this short-term restorative care program, or STRC. Both of those things rolled into support at home as of the 1st of November last year. And another big thing that changed was support at home brought along this single provider model, where essentially means that if you are a registered aged care provider delivering support at home services, you need to offer every single service. So not just support workers, nursing, gardening. You also need to offer, allied health. You need to offer the full range of services, basically. So prior to 1st November, that wasn't the case. You could offer just a select few. So, for example, one of these 855 registered providers before 1st November, they didn't have to offer allied health, whereas now they do. If you're a registered provider, you need to offer every single service under the single provider model. One of the biggest changes with support at home was that under the old program, under HCP, there was no cap on management fees that providers could charge. So we'll look at budgets and things a little bit later on. But for a consumer's budget, providers could charge a management fee for managing the package, case management, compliance, governance, all that type of thing. So let's say, for example, they got $10,000 of funding a quarter. A provider would charge a percentage of that, funding package to manage their package. That was up to 40% in some cases. So yeah, $10,000 package, we'll charge $4,000 for managing it. With support at home, that fee is now capped at 10%. So that was a huge change for the registered providers. They essentially were losing a huge amount of revenue because of this cap on management fees. So the theory was this time last year was like, less fees on management, more fees on direct services such as allied health, clinical services. Hasn't fully eventuated like that. But yeah, that was maybe one of the biggest shifts, was this huge loss in revenue. Registered providers needed to make it up somehow. The other thing that changed with this new Aged Care Act support at home is much stronger governance requirements and accountability, stronger standards and things which we'll look at in a second, and personal liability for directors, executives, and so on. So as we go through this presentation, governance is going to be a strong theme as we go along. And yeah, basically all tying together that these aged care providers who were already struggling a lot, not many of them were making much money, to be honest, a lot were losing money. They're under even more pressure now because they're losing these management fees. Basically, they've lost a lot of revenue. Expectations have gone up. They're getting squeezed from both ways. Some key dates to look at here. Again, 1st November was when this all commenced. It was scheduled for July last year. They pushed it back to November, which was a strange time to roll it out. And again, even then it was pretty undercooked, let's say. 1st of July this year, which isn't far away now, supposedly price caps are coming in. Again, we still haven't had really much, as of the time of recording, we haven't had much news on what this is actually going to look like, which is concerning because this is fundamentally going to change, again, from an allied health perspective, associated providers. This is going to change a lot in terms of what we charge. We don't know what it's going to look like. Hopefully they're high, but I imagine they're going to be lower than what we're hoping for. So yeah, price caps coming 1st of July this year, supposedly. We'll see. The other key date is that, which we won't dive into in this presentation too much, but 1st of July, or I think the actual the language they use is no earlier than 1st of July 2027. CHSP will transition to support at home. I said potentially here because there's a lot of advocacy and efforts from within the sector basically saying that CHSP actually kind of works how it is at the moment, whereas support at home is a shambles, to be honest. So yeah, people don't really want CHSP to roll into support at home, but that is the plan at this stage. So we'll see. But yeah, it's all meant to be aligned and under support at home as of no earlier than the 1st of July, supposedly. And then the other thing to consider is there might be changes to the registration model post 2027. So at the moment, we'll talk about registration a little bit later on, but to get registered, it's only really worth it if you're going to offer the full suite of services. So you can't, there's no point really getting registered just for allied health. You need to offer like, nursing and a bunch of other things as well. The single provider model, full suite of services. They've indicated that might be a bit more of a marketplace model, a bit more like NDIS, where there's a high number of registered providers. You can pick and choose. You can go to this provider for your domestic assistance. You can go to that provider, for your allied health, another provider for your gardening, that type of thing. So yeah, we'll spend a bit of time on this slide. I think this is useful to look at comparing support at home to NDIS. So a lot of this data is from this KPMG aged care market analysis, which I recommend anyone who's interested having a look at. Because again, it's both the aged care and NDIS sectors. They're coming together. So I think it was May last year they renamed it to the Department of Health, Disability and Aging. They basically restructure it so both disability and aging are now in the same departments or portfolio, if you want to call it. And I do believe both sectors are coming together a little bit slowly but surely, where NDIS is essentially the wild, wild west. It's so unregulated and out of control, whereas aged care is like highly consolidated, highly regulated. And I do think both will come together where aged care will get a little bit less, hopefully, consolidated. NDIS needs to rein things in a little bit. So we'll see both come together over the coming years. So yeah, looking at NDIS versus support at home, NDIS is about 300,000 providers operating, 94% of them are unregistered, whereas in support at home, as of the time of this report, there was 855 registered providers. Market size, NDIS, again, about $46 billion. Support at home, again, this was 24 financial year, was about 8.8 billion. It was a big increase. So again, to put it simply, NDIS are kind of like trying to clamp down the amount of funding. There's all just talks about cut the amount of growth. I do think support at home will continue to see funding go up because we have this aging population, boomers coming in, all that type of thing. Big voting population, want to keep them out of aged care facilities. So theoretically, NDIS goes that way, support at home goes that way, but who knows? NDIS referrals can sort of come from anywhere: participants, support coordinators, families. Support at home, it comes from like the case manager, they're called. If you're a provider working in NDIS, you can invoice the participant directly or their plan manager. If you're working at support at home as an associated provider, you're essentially working as a subcontractor. You invoice a registered provider. And again, if you're registered for GST, this is always a question that comes up is when you invoice, again, I'm not an accountant, this is not financial advice. Please check with your own accountant or do your own research. But if you're registered for GST and you're working as a subcontractor, it's a business to business relationship. So you should invoice them plus GST for your services. You don't charge GST on services direct to clients providing clinical work. When you're a subcontractor, you should. But again, don't come after me for that. Check with your accountant. In the NDIS, registration is optional for now. Probably going to be mandatory one day, but for now it's optional. And again, 94% of providers are unregistered. In support at home, it is mandatory for the lead provider or the funded provider. For 99.9% of allied health providers, you will operate as an associated provider or like a subcontractor. NDIS compliance, moderate. Honestly, I would probably say low. Like it's just there's really like nothing really. Which is a shame, to be honest. In support at home, the compliance requirement is high and increasing, and the provider will be held liable for your work, which we'll cover and talk about. NDIS, super unconsolidated sector like the Wild West. So many sole traders and small organizations out there, 300,000 of, majority would be small. In support at home, it's a highly consolidated and corporate sector. So of these 855 providers, the top 25 hold 40% of the funding. And you can see that in this market analysis here. So super consolidated sector. Budgets, again, NDIS budgets of all sizes. You can have really high, expensive plans, 200K plus, much higher than that. Support at home budgets are comparatively a lot lower. We'll look at a table, looking at all the levels a little bit later on. Travel, yeah, in NDIS, you can bill for it, kilometers, all that type of thing. Support at home, you can't bill for travel anymore. We'll talk about that a little bit later on. So yeah, what's the opportunity for allied health in support at home? So yeah, at the moment, there's about 200,000 people, last article I saw, waiting for home care packages or support at home packages. So there's huge demand for, this service. So again, I'm hoping they'll release more packages, or again, I know pressure on the public dollar is pretty tight at the moment, and it's still a pretty big market. But yeah, this new single provider model means that, not every single provider offered allied health, whereas now they have to. So again, they're looking for allied health partners, the ones who didn't already have it. We'll talk about it, but a lot of support at home providers would try to do allied health internally. But as if you guys listen to this as allied health providers, you know that clinicians are they'd rather work for an allied health company rather than a generic aged care company. Not always the case, but in general. So yeah, aged care companies will struggle to recruit and retain their own internal allied health teams because these clinicians would rather work for clinical companies in general, or they don't have the referral pipeline to have a part-time or a full-time physio, OT, speechy, whatever. Couple terms that came out with the support at home reforms are like wellness and reablement, which are mandatory under the new Aged Care Act and strengthened standards and so on. So wellness is basically like ongoing maintenance, that type of thing. Reablement is getting people better after a fall or hospital, going to hospital, that type of thing. So again, allied health obviously help with both of them. These new strengthened aged care standards, in particular standard 5 clinical care, there's a lot of emphasis on the quality of your clinical care, both nursing and allied health. So again, there's a much higher bar in aged care than there has been previously in terms of the standard of allied health and outcomes expected. Yeah, that management fee cap means that providers need to get creative with where their margins coming from. Basically, again, like I mentioned before, aging population. We have this huge, the boomers are coming. We've been talking about it for decades, really, that these boomers are going to hit the aged care system. My theory behind it is that they don't want to, the government or whoever doesn't want to build all these extra aged care facilities to house all these boomers, because once all the boomers age out, all the facilities would be empty, right? So again, my theory is that we want to, the boomers, they're grumpy, they're vocal, big voting demographic. They don't want to go into aged care facilities, right? Who helps people, who helps maintain independence, keep them out of aged care? That's allied health, right? So theoretically, the government or whoever should invest into us as a sector, because we can, assist in maintaining, these boomers, getting them independent, getting them mobile, that type of thing. And the other thing too is co-contributions. I won't go into it in detail, but that's been a huge concern for consumers in support at home, having to co-contribute to their services where previously they didn't have to under HCP. The good news is for direct clinical services, there is no contribution that clients have to make. There is a little bit on, equipment and that type of thing, but no contribution for direct clinical services. All right, just a few buzzwords, I guess you could call them. If you are wanting to, expand into support at home, or if you already do, you just want to make sure you're using the right language and talking about talking about the right things, because it's a bit like if you're doing NDIS work, you're not using the words like participant and that type of thing. You kind of don't look like you know what you're talking about. So yeah, same thing with support at home. You just want to know a few key terms that you can, chuck into your emails and your outreach and that type of thing. So obviously support at home, SAH for short, single provider model, we've talked about a little bit before. Associated provider is the term, where again, previously it used to be called like subcontractor or a brokerage or something like that. Now the official term in all the documentation is called like you are an associated provider. So you deliver services under someone else's registration, essentially. These strengthen quality standards. That's the new aged care quality framework that providers are assessed against. And it's a bit like in childcare, for example, like they have their standards and it's all public, and that if an aged care provider fails an audit against these standards, or there's some there's essentially like a black mark against their name that's public for everyone to see. So again, really like they care a lot, as they should, about these standards and meeting these standards and passing audits and all that type of thing. Standard 5 clinical care is the one that relates to us the most. Wellness and enablement, again, I actually don't really love these terms, but they are very common with what we do. All-inclusive pricing, again, your direct rate, you can't bill for travel in support at home. We'll talk about that a little bit. But yeah, direct rate, indirect rate, two terms to be aware of. And then the case manager in support at home, they're like the equivalent of a support coordinator. They, schedule supports, funding, all that type of thing. So yeah, so these are the funding levels in, and yeah, again, these are just example, from one of the manuals. These are sort of the funding levels and how it works in support at home. They're set quarterly budgets. It's not like NDIS where like plans are, well, currently it might be a bit different under new framework plans, but it's not like NDIS where plans sort of get made up and they're, change from year to year, or, you don't know what you're going to get. It's a bit of a lucky dip at times. Support at home, it's a set budget, set quarterly budget, depending on what level they're assessed at. And that will just repeat every single quarter. So again, the budgets are, in general, a lot lower than NDIS. So you're not going to get the huge amount of allied health hours or behavior support or SIL or support worker or whatever like you would in NDIS. And this budget needs to cover everything. So, nursing, support workers, allied health, transport, gardening, all that type of thing. They'll also take their 10% management fee from this as well. So, yeah, when you're thinking about what you have to work with in support at home, it's nowhere near as much budget as you often have to operate with in NDIS. And we also have these sort of, on top of these regular quarterly budgets, we also have these sort of short-term programs, which we'll look at in the next slide. But yeah, this is where like the good thing about it being consistent is this is where like wellness can be really beneficial, where like let's say someone's on a level 5 package, you can sort of budget for like weekly physio sessions or fortnightly physio sessions or something like that, where it's just sort of, you can sort of set your watch to it a little bit better than NDIS, which is just like, it's just wavy and all over the shop. These short-term programs, again, I won't go into full detail, but basically on top of these, on top of these set budgets as well, there are these 3 different short-term pathways as well. There's this restorative care program, which can be usually 6K, but up to 12K across 12 weeks, where they might get some short-term therapy. It might be they've had a fall, they're coming back from hospital, all that type of thing. There's actually, I don't think there's loads of these being released, but they do come along every now and then. The AT home mod scheme, obviously, particularly any OTs listening to this, there'll be a lot of funding allocated to this. 3 separate levels they can be allocated: low, under $500. Again, not much funding there. Medium up to $2,000, high up to $15,000, and then they can get extra, based on approval and all that type of thing. And then palliative care end of life program. Again, allied health, not a huge involvement in this, maybe a little bit here and there, but yeah, there is these 3 short-term pathways as well. All right, let's talk about, I call these the big 5 disciplines in aged care. So I'm sure there are probably people who aren't from these disciplines listening today as well. There are little bits and pieces scattered here and there for disciplines outside of this, but these are the big five, I call them. And no coincidence, this is the five that like Plena offers, for example. So we'll talk about each of them quickly. So in aged care, physio is probably, I would say, like the height. Physio is like bread and butter, let's call it, where it's probably the most sort of ongoing caseload in terms of like, regular wellness, maintenance type sessions. Not the most like, let's say, exhilarating work, but like, with those set budgets we're looking at before, they can have, fortnightly physio sessions, exercise program, that type of thing. It's pretty, there's a lot of that in support at home. And then there's also obviously reablement, falls, all that type of thing. But it's probably the one discipline that providers will try to do internally first as well. So they will try to recruit their own physios more than any of these other disciplines. But yeah, very, very common in support at home. OTs, again, very high demand for like, reablement, assessments, AT, home mods, equipment trials, all that type of thing. So in terms of from a provider perspective, it can be harder to like sustain a purely aged care OT caseload because you need so many referrals. You need a constant flow of, in terms of the hours you spend on, on these AT and home mods and that type of thing compared to NDIS, it's a lot lower. So yeah, it is harder to sustain this episodic caseload. Again, there are ongoing, there is ongoing work and that type of thing as well, but not as much as physio. But yeah, the other thing too is for OT, there are a lot of OTs who are interested in aged care who are like burnt out from NDIS or want to change or want to diversify. Speech pathology, much lower like volume and demand than physio and OT, but there's also a huge workforce shortage. So these aged care providers, the registered providers, there's no chance they, again, other than the huge, enormous ones, for the vast majority, they're not going to have their own internal speech pathologist. One, because they can't recruit them, or two, because they don't have enough referrals to sustain a caseload. So they'll most likely go associated. Dietetics, again, pretty still pretty high demand. I should maybe make it moderate rather than low. But yeah, for dietitians, there is a saturation of the workforce. So if you go on Seek, I think there's about like 3,000 OT job ads, whereas if you search for dietetics jobs on Seek, there's about 100 active. So there is a lot of, it's the easiest discipline to recruit out of any of these. But again, a registered provider probably won't have the caseload to sustain a part-time dietitian. So they'll just get a subcontractor or someone as an associated provider. And then for podiatry, there is a very high demand in aged care for podiatry, but it's impossible to recruit. So the providers have no choice but to go associated. In terms of the stats, if you look at the AHPRA financial year, if you look at the AHPRA annual reports, in the 24-25 financial year, there were 4,100 physios who entered the workforce, 2,800 OTs who entered the workforce. There was only 221 podiatrists. So we're pumping out like 20 times more physios than we are podiatrists. For every one podiatrist, there's 20 physios entering the workforce. And yeah, of these podiatrists, only 140 were domestic too. So yeah, not many new grads, a few from overseas. So yeah, podiatry. And again, I say this to anyone who's thinking about, hey, I'm a physio provider, or I do physio and OT. Should I add podiatry? I'm like, yeah, just don't bother. Podiatry it's impossible. We need a lot more podiatrists. So yeah, bit of an overview there of the big five disciplines in aged care. So yeah, I touched on this before. For the vast majority, 99% of people listening to this and 99% of allied health providers, don't bother getting registered or even looking into it or worrying about it. Just operate as an associated provider for now. To get fully registered, it costs about 20K in fees. You need to go through audits. You need serious governance, all that type of thing. You need a nurse on your team or board or something as a key personnel. The application form, if you ever look it up, is insane. I think it's about 100 pages. Just don't even bother. You need to operate as a single provider. You need to offer all the services. Really not worth it for now. What you want to do is you want to operate as an associated provider. You are essentially a subcontractor delivering under their registration. But yeah, the one thing with sort of this associated provider model is that And a big difference compared to NDIS, I probably should have had it on that NDIS slide, is that there's no choice and control in aged care. So in the NDIS, participants can choose who they want to see. I want to go see Trystan the physio. I want to go see that person's my OT. It's written into the legislation, which is awesome. There's nothing like that in aged care. They just basically, if the registered provider has their own clinician, physio, OT, speechy, they will, and they can basically say, no, you have to see who we're telling you to see, type thing. But yeah, like I said before, this might change. We may get more of like a marketplace model from 2027 onwards. Pricing, again, we could spend 45 minutes just talking about pricing itself. So I'll give a bit of an overview anyway, because yeah, it's a bit of a debacle, and we have price caps coming July 1 as well. So yeah, basically pricing, it's still, yeah, we had this fact sheet that came out. I think it came out like maybe 3 weeks before Supporter Home rolled out, where essentially it broke up allied health rates, but also I think nursing as well, into this direct rate and indirect rate, where, like I mentioned previously, Support at Home has this all-inclusive pricing where you can't bill for travel in Support at Home. You need to load it up into your direct rate. So essentially what that means is your direct rate should be higher and inclusive of travel, where, yeah, whatever you're charging for your direct rate, X amount of dollars should be your face-to-face time with the client, include travel loading, and whatever that comes out to be. And then your indirect rate is essentially what's your, like, you call it like non-face-to-face time in NDIS or telehealth or report writing time or whatever it may be. So that all sounded well and good, but the issue is that if you are charging an accurate direct rate, so let's just say, to keep the numbers simple, my base rate is $200 per hour. I charge, and then let's say I did a 30-minute session, $100, and then I do 15 minutes of travel, whatever that is, $50. So then my 30-minute direct rate is $150 for half an hour, because it's inclusive of travel. So then my effective direct rate should be $300 per hour. I think that maths is right. So that's kind of what these fact sheets and the legislation and stuff from the government says. But then if you go to a registered provider and say, hey, my direct rate is $300 per hour, they're going to say, that's way too high. We're not going to invoice our consumers that, because it just looks too high on their monthly statements. So again, I won't go into pricing in too much detail, because it is a whole topic in itself. But with your pricing, you need to be creative, because you need to keep it as low as possible, because whatever your rate is that you're invoicing the registered provider with, they're going to charge a margin on top of that too. So the price you're charging them, they put a percentage, 10, 20, whatever, on top. And that's then reflected on the client's statements. And if they, which is what they're all complaining about, these poor consumers, they're like, all their rates have gone up, but they don't really understand why. And again, it's an absolute debacle, to be honest. So yeah, you need to be creative with your pricing, and try to keep it as low as possible, because yeah, providers want to keep that rate on the statement and their advertised rates as low as possible. And then the other thing too is someone at the door, mailman, I think. The other thing too is, particularly for Metro, is if the registered provider has their advertised rate at, let's say, $250 per hour, it can be like a race to the bottom, because the provider wants as much margin as possible. So generally, for most people listen to this, I would say you don't want to be. It can be a trap getting stuck in that race to the bottom, because we just get racing. Again, this happens in both community and residential aged care, where it's just like, who can do it for the absolute cheapest. I don't think you necessarily want to be the cheapest option out there. You want to be reasonably priced and offer value in other ways. But yeah, in general, rates and total hours are going to be much lower than the NDIS. So you need to work a lot more efficiently. You generally need to do things a lot quicker, shorter, sharper, less detail than the NDIS. Compliance. So this time last year, if you asked me what providers would care most about in supporter hire, I would say pricing was number one. I actually think pricing is now the number two thing they care most about. The biggest priority, the thing they care about most is compliance. So, like I mentioned, this new Aged Care Act brought in much stronger governance and compliance requirements for registered providers, and it also increased the penalties they face and their I guess their obligations for their associated providers also increased as well. So previously, under the old system, if you're an associated provider or the gardener or someone like that did something wrong, you'd kind of get in trouble, and the registered provider's like, oh, it wasn't really our fault. It was the dodgy lawnmower man's fault. Whereas now, if you do something wrong, the registered provider gets in trouble. You are their responsibility, basically. And the other thing, too, is that with the new Aged Care Act, now like executives, board members, that type of thing, they can be held personally liable as well. So with this new, amongst everything else that's going on with the rollout of support at home, all the registered providers are terrified about their associated providers, and most have reduced their panel of associated providers, coincidentally. So I've heard some providers reducing their panels by like up to 80%, to be honest, because they want high quality, ethical providers with really good governance. So yeah, basically you need to, again, I think your governance and your compliance should be your number one sort of pitch you're giving to these providers. So bonus points if you're NDIS registered. I think it shows that you have systems and processes that most don't. So yeah, you need things like incident management, complaints, worker screening, SIRS, that type of thing. Again, you need a lot more than you've previously required for most funding schemes. In NDIS, you can sort of get away with nothing currently. I think that will change. Same thing as a subcontractor or brokerage partner previously under HCP. Now under support at home, your governance requirements have gone up because they're terrified about their associated providers. And as there's a bit of a leniency period where the department's going to go a bit easy on these registered providers as things are rolling out, that type of thing. But as the program matures, these registered providers, they'll start auditing their associated providers. So they're going to ask for checks, balances, policies, procedures, registers, all that type of thing. And I understand that's very hard for associated providers because you have different requirements from multiple different providers. But yeah, basically governance is absolutely massive in support at home. I think this is kind of where NDIS is heading. It's slowly getting there as well. So the reality, if you're trying to break into support at home, it's really, really hard. Cold outreach is the primary way of breaking in. If you have no existing support at home relationships, it's possible, but it's very, very hard. It's going to be a long slog. Like hit rates are low when doing outreach. It's not like it's like the total opposite of NDIS, which is still challenging. But yeah, if you want to break into support at home, you're going to need to do it at volume. You're going to need to be persistent. You're going to need good systems and processes around it, because the sector is consolidating. So all these registered providers, they're all cutting their number of associated providers, not just allied health, but also other services as well. So if you don't have great governance, you're going to get, cut first. And then the other thing is that by now or previously, pretty much all these providers had, or they have allied health relationships. So if you're trying to break into support at home, you're displacing an incumbent, right? So you need to be offering some kind of better service or better value or different unique selling point to the provider they're already working with. So you need to think about what that actually is. The other thing for support at home is it's going to be very tough for sole traders because of this governance requirements. Again, there's obviously sort of a lot of sole traders who are awesome and do a lot of this work and who have existing, because they've been doing it for years, they have the documents, all that type of thing. But for let's say a sole trader who works in NDIS who wants to do some support at home and start, it's going to be hard because again, these 855 registered providers, they want rock solid, reliable, providers with good systems and processes, risk management, governance, all that type of thing as well. because yeah, they're very risk averse. Their reputation, their registration is very, very valuable. And then the other thing too with this as well is that for these incumbents, for the allied health providers who already have existing support at home relationships, a lot of them were doing this work when aged care wasn't as glamorous. It's in vogue now. Like if I ran this webinar a year ago, I wouldn't have had as many people attending. Whereas now everyone's like, oh crap, NDIS is in trouble. Let's go into support at home. A lot of the guys who have strong existing support at home aged care relationships, they were doing it when it wasn't as glamorous. It wasn't as high charge rate and margin and that type of thing too. So yeah, it's going to be hard to displace them. It can be done. But you need to have a think about why would someone choose you over someone they're already using. And then for those who do have existing relationships, again, I could spend a whole 45 minutes talking about this too. You need to think about if you have any warm leads or existing relationships, it's a lot easier to get more referrals out of them than to do cold outreach and bring in new ones. So use account management strategies to get more referrals out of people who already know you or already have referred to you or are referring to you. And then I talk about this a lot. If you want aged care work or NDIS work, go regional. Like Metro is so saturated for allied health. It's insane. And in aged care, where it's like a subcontractor relationship, it's a race to the bottom. It can be a total race to the bottom. Who's the cheapest? Which provider I'm going to make the most margin out of? And it's not like a great game to be involved in. So if you want the work, go regional. This time last week, I did a presentation at a PHN in Bendigo, and there's maybe 25 providers in the room there. And I asked who does aged care work in here, and no one put their hand up. No one in the room was doing any aged care work. So there's so much demand. They don't have to because they have such long waits for NDIS and Medicare and private and that type of thing. So yeah, if you want aged care work, go regional. It's a good way to break into. This is the strategy a lot of providers use. My whole company as well with aged care is do the, even me as a new grad, do the regional work, do a killer job, and then you can pick up metro work. But yeah, much, much easier to break in regionally. So yeah, bit of a summary, what providers are looking for. Compliance, again, absolutely massive, number one priority now. Compliance is, super, super important. Communication and customer service as well. Honestly, I think this is something that gets neglected a bit in allied health. We focus so much on clinical outcomes, which are important, and clinical service, but we neglect basic customer service skills. So being responsive, easy to deal with, regular updates, regular reporting, fast turnaround times. Again, a lot of this will be done naturally, but this can, the bigger a company get, the worse. The bigger, provider gets, the slower and the worse it can get. So yeah, communication can be a point of difference. Clinical outcomes. This is also where NDIS is heading as well. So again, it's written into the standards and programs and things, particularly for like the short-term programs. You need actual outcomes reporting in support at home. And again, I don't think the registered providers are fully across this yet, but if you guys can show good outcome tracking and reporting, it'll sort of put you ahead of, it's like you're like ahead of the game type of thing. So again, I would incorporate this into your practice. Useful in NDIS too, because this is where things are heading in there. And yeah, pricing, very important as well. Needs to be all inclusive, needs to be competitive. The hourly rate needs to be as low as you can get it. Metro can be a race to the bottom. You can get higher rates regionally. So yeah, what gets traction? Lead with compliance, governance, and pricing in your pitch. So if you're doing an email to someone, a brochure, whatever it may be, they're the things that providers care about. Again, which I think is a kind of cool thing that governance actually matters, to be honest, because again, it's in our sort of fragmented small allied health sector, NDIS, wild, wild west, even like private paying services, no one really cares about governance that much. Whereas in support home and aged care, it matters a lot, which is good. And again, NDIS is heading that direction too. If you want to crack into aged care, you need to have a structured outreach system. You can't just send an email to someone and, sit back and hope. It takes time and effort to break into aged care. So you need some repeatable systems to do outreach. You need a clear point of difference too. Again, this is something that I think particularly, allied health companies really struggle with is there's a lot of boring allied health companies out there, right? So if you're going to break into this hyper consolidated, pretty established market, why would they choose you? What's your point of difference? So is it you work regionally? Do you have a specialization area? What's your niche? Languages can be a great one if you speak any languages. Do you have great governance? What's your communication like? Have a think about what your points of difference are and why someone would choose you. And then the other thing, if you already have some work, is you need to invest into account management. Again, super neglected in our sector is getting more referrals out of people who already refer to you using account management strategies. Is it, summary emails, check-ins? If you want to go next level, it can be SLAs. So having like, we will we'll respond to 90% of referrals within a certain amount of time frame. We'll turn around X amount of reports in X amount of days, that type of thing. If you can go next level on this stuff, it'll just set you apart from every other allied health provider out there. So yeah, that'll pretty much do us. I'll look through the chat now and find us, look through to see if there's any questions to answer. But yeah, if you guys want, you can sign up to my newsletter. I'll break down any sort of allied health reform stuff as it comes along. You can book in to talk to me for a 20-minute strategy call, and we can talk through anything. We can deep dive into any of these areas with support at home. Because again, this webinar is just scratching the surface, to be honest. There is so much that's changed, so many nuances with support at home, and so much still to happen, to be honest. So yeah, I love talking about it. So book in for a chat and I'll see how I can help. But yeah, thanks for coming along, and I'll look through and see. I'll scroll through this chat and see what questions to answer. With support at home levels, does this only apply to one, new clients entering the system, two, clients have applied for and been approved a higher classification they're currently on? Otherwise, aren't grandfather clients still just on levels 1 to 4? Thanks, Regina, who asked that. Honestly, I don't fully know. I think, I can't fully answer that. I think they were grandfathered onto a bunch of different levels. It kind of depends. I think it depends on each client. But yeah, I do know the whole assessment process and grandfathering and rollover has been a bit of a mess. So yeah, generally from an allied health perspective, I don't think you need to, not like NDIS, where you need to stress too much about like managing their budget like you would in NDIS. You can kind of just sort of do what the case manager tells you to do or allocates you, and then that should be fine. So yeah, I don't know what levels they all went on to, so I can't really answer that. Sorry. Christina White says we should be ensuring allied health are well represented, engaged in end of life pathway referrals. I totally agree. I think I think that's something we should sort of be advocating for, is like our involvement across all stages of care. But yeah, allied health's, our involvement we can have in end of life. I agree. I think that's something we should be, advocating and pushing for. Roberta says, I'm having pushback from case managers regarding equipment recommendations. Some are under the understanding physios can't recommend recliner chairs and four-wheel walkers, while others ask for the trial hospital beds. Where do we draw the line on the scope of practice in the support at home? So yeah, I think I think that has to do a bit of education, I guess. So, and again, I think that's also, some of the disciplines having like identity crisis and that type of thing as well. I think, maybe just have some resources or some things you could educate case managers and providers on in terms of what different disciplines can prescribe, evidence of ones you've prescribed previously before. But like physio can obviously do some, basic, AT stuff like that. And yeah, Christina added, all AHP should work within their scope of practice, definitely. So again, you need your own responsibility for that. It needs to be within your own scope of practice. But yeah, I think in general, scope of practice is something, it's a bit of a hot topic again across NDIS and things as well. Robert asks, can support at home fund psychology support? So again, this is a pet peeve of mine that I guess it can fund. There's a list of allied health supports it can fund. So it just never does, unfortunately. Again, My company, we got like one every 6 months, maybe even less psychology referrals. It's a real shame. It breaks my heart, to be honest, in both community aged care and residential aged care, that mental health is just like ignored. So yeah, it can be. It just isn't very often, because usually the answer with psychology is same kind of thing is happening in NDIS a little bit. It's just like, go get a mental health care plan, go get your 5 sessions through Medicare type of thing. So yeah, it's not often funded, unfortunately, in support home. It's not seen as, which again breaks my heart across residential and community, that mental health for the oldies isn't taken more seriously. But it's just yeah, it's just where things are at the moment, unfortunately. Regina said, aren't registered providers billing the clients their rates published, not our rates? So yeah, that's correct. So whatever they charge, again, we'll just say, $250 per hour for, X discipline service. That's what will show up on the client statement. You then, you then invoice them as a subcontractor with some margin underneath that. So previously, under the old system, HCP, they weren't always taking a margin on top of our services, because we offered, because there were such high management fees. So yeah, because they could charge up to 40% management fees, they were like, oh, okay, allied health, whatever, we don't really care. You go do your service. We don't need to make any money on you. Whereas now they do need a margin. So another thing on that is, don't ever, if you're working with a client directly in support home, don't tell them what your charge rate is, because it's going to be higher than it's going to be lower than what is on their monthly statement. They're going to get confused. So yeah, that gap, that margin, that race to the bottom is one of the issues in support at home. Anything else? I think that's most of the questions. So yeah, anything else? Send me an email through afterwards. Book in for a call with me if you'd like. Otherwise, yeah, it's going to be an interesting year ahead for support at home, amongst NDIS reform and all that type of thing with allied health. Again, maybe I'm glass half full, but I'm hopeful. Again, I'd love to see better advocacy around aged care and allied health. I feel like it kind of gets neglected. Like we spend so much time, talking about NDIS and so on and that type of thing. Aged care feels like it kind of gets forgotten about, to be honest. So yeah, I hope, again, this aging population, keeping people out of aged care facilities, that type of thing, allied health can really help with that. So I'm hopeful that taxpayers, policymakers, that type of thing can see our value. So yeah, hopefully it's good to see all the interest people have in aged care now. Again, no one's really cared about aged care for the past 10 years of my career, whereas now people are interested in it, which is kind of funny. So yeah, book and record with me, send me an email. Happy to have a chat, talk to anyone about aged care. But yeah, thanks everyone.